This is a robotic band to sleeve conversion. So what we're doing on this patient is removing a laparoscopic adjustable gastric band. She had this placed about 7 years ago. She initially lost quite a bit of weight, about 80 pounds or 60% of her excess weight. She eventually, however, gained some of the weight back and developed one of the side effects that's common with the lap band, and that's gastroesophageal reflux disease. The way the lap band works is that it has restriction at the top of the stomach, and as a result, for some people who are prone to gastroesophageal reflux, it can weaken the lower esophageal sphincter. So the food that they eat, the liquid that they drink, and sits in the area of the stomach above the band can reflux up into your esophagus and be very uncomfortable. So she had this symptom and she had gained some of her weight back. So after analyzing her diet and doing a nutritional evaluation, talking about the risks and alternatives of the operation, we decided to remove her lap band and convert her to a sleeve gastrectomy. Here we dock the robot and we have instruments placed into the abdomen. This is the left lobe of the liver. And you can see there's some scar tissue. That's me. I'm sitting at the robotic console, which is in the same room. But whatever my fingers are doing, these instruments are doing, and they're doing with a very high level of precision. And so I'm able to do things in a very small area of the abdomen. What you're seeing in the video on the inside of the abdomen is magnified. These instruments are very small. They're only about 1 to 2 centimeters in size. And what they allow me to do is to do very intricate, very precise movements using the robotic instruments. And you can see that this particular device is called the Da Vinci Surgical System, made by Intuitive, and this is the Da Vinci Xi robot, or the newest model that they have. So I'm using a scissors, which is electrified with what's called monopolar electrocautery. And this allows me to cut and cauterize tissue at the same time so it doesn't bleed. I'm exposing her lap band. It's covered with scar tissue. You can see the insignia there. It says Allergan. That's the company that manufactures the lap band. I want to be clear, the lap band works very well for many, many patients. For some, it's not great for their weight loss, and for others, it causes side effects, like in this patient. And so we're unbuckling the band. This is around the top 2 or 3 centimeters of the stomach. And because of the scar tissue and the capsule around it, there is a little bit of difficulty taking out. You have to be very careful not to damage the stomach, not to damage the esophagus, and not to damage the liver. In this case, the band is actually scarred to the liver, to the stomach, and to the diaphragm, which is at the top part of the screen. You can see it beating there. The heart is right behind the diaphragm, and that's what you see beating. This patient made a lot of scar tissue around the band. It was fairly difficult to remove. So what I decided to do is cut it in half, because on both sides of the band, there's a large portion of the buccal. So by cutting it, I'll be able to pull the two halves out in opposite directions from around the top of the stomach. On the inside of the band is fluid. You can see some of that fluid leaking out from the tubing that I also cut. And that kind of releases some of the pressure from the inside of the band, also making it easier to remove. So now I cut it in half. I'm going to remove the other half of the band like that from around the capsule. You can see that whitish tissue is just scar tissue. Now we're going to prepare to do the sleeve. To do the sleeve gastrectomy, we're going to take down the attachments and the vessels from what's called the greater curvature of the stomach. This is the long end of the stomach. It corresponds to the left side of your abdomen. So we're looking up into the patient's abdomen here. So on the right side of the screen is the left side of the patient's stomach, corresponding to the left side of their body. These are vessels called short gastric vessels. All this part of the stomach is going to be removed. In fact, we're going to remove 75 to 80% of the stomach. using a surgical stapler. So all of these vessels here that I'm cutting are going to stay in the abdomen, and the stomach on the left is going to come out as specimen. So the surgical robot is a very, very neat instrument. It is a tool. We call it a robot, but it doesn't operate by itself. It's not autonomous. Everything that we do with our hands is repeated by the robot inside of the patient's body, again with a very high level of precision. This device is also a very neat device. Like the scissors I used to expose the band by cauterizing the scar tissue, this is called a vessel sealer device. The electricity moves between two jaws of the instrument, and it cauterizes these substantially larger vessels. There's the spleen there, which these short gastric vessels from the stomach actually attach to. And the spleen can be very fragile, and so we have to be very careful. This part of the operation is very intricate and requires a high level of precision, and you can see the robotic arms working on the outside there, translating to the miniature movements on the inside. I also have a surgical team. You saw some of them there. One is my partner, Dr. Ryan. She's at the bedside helping us to assist, to help exchange instruments within the robotic arms, to troubleshoot any issues that occur, to be there in case there's an emergency. So it's very critical that you have a good team during a robotic operation. You can see again here that the scar tissue at the top of the stomach as a result of the band caused the top of the stomach to adhere to the diaphragm, and I'm using this vessel sealer device to remove that scar tissue. Now we're ready to do the sleeve. To do that, we're going to pass a sizer, a rubber tubing called a bougie. The anesthesiologist is helping do that for me through the mouth. And I'm going to use that as a guide. That's going to tell me how large the rest of the stomach is going to be that we leave behind. That's going to be the sleeve gastrectomy. We're using a robotic stapler here, which is a motorized, computerized stapler, which both cuts the tissue and seals the two edges of the cut stomach. And that's what's known as the stomach stapling. Here, this is the second firing of the sleeve. This stapler is going to follow right up the stomach, right up to the diaphragm where the esophagus turns into the stomach. It's going to be one long tube. And the total volume of the remaining stomach is going to be anywhere from 6 to 8 ounces. And so when this patient eats 6 to 8 ounces of solid food, they're going to feel very full. The stretch receptors in their stomach is going to send signals, hormonal signals to their brain telling them that they should stop eating, that they feel full. So it's not purely a restrictive operation. We call this also a metabolic operation. It uses aspects of your metabolism, your hormonal mechanisms to tell your brain that you're done eating. Like any weight loss operation, however, this is just a tool. If you wanted to drink a lot of high calorie liquids, if you wanted to eat chocolate and chips and ice cream, you can get enough calories in to gain weight. The key here is to have a good relationship with your bariatric program and to understand that this is a lifelong lifestyle change. Here we're completing the sleeve gastrectomy. My team's getting ready to very soon help me undock the robot and remove the cut portion of the stomach out from the abdomen. There's a lot more scar tissue up here than you would see in a normal sleeve without a band removal, and you can see one of my other videos, or one of my other 2 or 3 videos that show that. You can see some old scar tissue, some old stitches that were used to secure the band. And so this operation does require a little more care. You have to really check the staple line, make sure everything looks nice and sealed, nice and healthy. The biggest problem that can happen in this type of operation is a leak. Here you see a little bit of bleeding, and we're going to control that with some electrocautery. And it's really not a lot, it's just 1 or 2 ounces, and we can easily stop that. Thank you very much for watching.